What we are going to do is we are, instead of each one of us teaching you at the bedside station the same thing over and over again, I'm going to show you how we scan all these nerves on a volunteer. Thanks to Paneer Selvam for volunteering for us for this. The probe that I use for most of my upper limb block is a high frequency linear probe. Where did he go?
Ma'am, 1 second.
Okay.
Okay, you're on.
Okay, so this is the probe that I use. When we say linear, the surface is flat. The ultrasound rays are going to come parallel to each other. That means your screen is going to be straight and square. Okay, so that's a high frequency linear, which is 7 to 12 megahertz. Okay, I'm going to start from the interscalene and go down gradually. Okay, for the interscalene, I usually have the patient turning the head slightly to one side. I let them come and focus the camera. Sure. No, I was going to point with this one so that it's. Oh. Okay. Yeah, okay. Sure. No, அந்த பக்கமே பண்றேன் எனக்கு I'm right-handed. So we teach a lot about ergonomics. You shouldn't be turning to look at the ultrasound screen. It's supposed to be across from me. But I'm not following that rule because I want to adjust the ultrasound images, whatever I want to adjust, and I want to be within the reach of my machine. And I also want to give them a chance to focus on my hand. So I'm not really truly ergonomic. But when you go back, follow the ergonomics to keep yourself comfortable when you do these ultrasound blocks. Ultrasound will not work unless your contact is good. So we use an ultrasound gel, and I cover it completely with ultrasound gel so that the contact is good between the probe and the patient. Oops. Okay. And with any ultrasound machine,
can you go live?
I will tell you. You want a camera on?
Sorry about the delay. We will get it perfected within the next few minutes. Okay. Okay. So if you watch this probe, there is what is called a notch. This notch corresponds to the blue dot on my machine. So can you show on this machine? Can you show this machine? So do you see a blue dot on the top left screen? The notch corresponds to the blue dot. So if I'm going to orient the blue dot towards the side of the patient, okay? So there are two ways of getting to the interscalene groove. You can start from the supraclavicular area, okay? So now I'm going to put my probe parallel to the supraclavicular, parallel to the clavicle. What do I see on the screen? I see a pulsatile artery, and there is a bunch of grapes just to the left towards the blue dot side of the artery. Those are the supraclavicular brachial plexus. Just underneath the artery, you see a hyperechoic shadow which is not moving with respiration. That is the first rib. As I go a little bit more laterally, you see the step and the shimmering pleura deeper down. Is it showing nicely? No, it's not showing quite. I'm going to increase the gain at the bottom. And I will increase the depth a little bit. No, I wanted to increase. Okay. So now you can see the pleura. Can you show the pleura, shimmering pleura lower down? Yeah. I can use the pointer. The shimmering pleura is that one there. Okay. Can you see the shimmering structure? Can you take a big breath? Can you see the movement there? That is the pleura. Okay. Okay, so now you see a hypoechoic shadow here because the first rib, so the first rib is there. So underneath that there is nothing seen, it is all black because the rib does not allow the ultrasound waves to go through. So now I've got my basics, okay, I'm going to reduce the depth. So when I'm going, so that's the subclavian artery. brachial plexus, and they talked about the omohyoid muscle. There it is there, omohyoid. Omohyoid cholidone. Okay. So we talked about the omohyoid muscle. So that is the omohyoid muscle. Okay, it's running across the brachial plexus, sandwiching it between the first rib and the omohyoid muscle. So now you have the subclavian artery, okay, and we are going to put a color Doppler to show you the subclavian artery. So that is the subclavian artery riding right on top of the first rib. So I'm going to move my probe more medially, and you see a muscle just to the right of the subclavian artery. That is the anterior scalene muscle getting attached to the first rib. When I go more medially, I see a big fat vein, and in fact that is the subclavian vein. I'm going to put off the color Doppler, and what you will see sometimes is even some valves in the subclavian vein. So that is the subclavian vein where it is about to join the internal jugular vein. Now you can see the valves flapping in that area. Okay, so I come back out, I get the view of my subclavian artery. Now I'm going to toggle my probe to be perpendicular to the interscalene groove. Now I start to see the scalenus anticus, okay, and you can see the sternocleidomastoid where that white arrow is, and you can see the interscalene groove with the brachial plexus, and you see the scalenus medius. Okay, so I'm going to go up a little bit more. I'm watching at the bottom of my screen, looking for my transverse process of the C7 as well as the vertebral artery. There we go. Now I got the transverse process of C7, and you see some pulsatile structures. That is the vertebral artery. Can you put a color Doppler there? See, can you see those pulsations there? Those are the vertebral artery pulsations. Okay, you can take off the color. So now the oblique white line is the transverse process. No, not this way. So the oblique white line here is the anterior surface of the C7 transverse process. Watch it, and there is a black structure sitting to go into that as I go up. That is the one that is going into the transverse process. So that is the C7 ventral ramus. Can you see that black round structure? And when I come down, you can see the C7 transverse process. When I move my probe up, C7 ventral ramus is going into the transverse process. Now I'm going to look for the next transverse process I will see will be the C6 transverse process. Okay, so I'm looking for, there we go. Can you freeze it? Freeze it at the bottom of this. There we go. So now I'm going to show you some of the structures that I have identified. I see a black round structure there, that is the C6 ventral ramus, and this cup-shaped structure is the transverse process. Occasionally I may even see a dural sleeve around the C6 ventral ramus, and this shadow is the anterior tubercle of C6, and this shadow is the posterior tubercle of C6. And I already see the C4-5 bunch of nerves more superficial to the C6 ventral ramus. When I do my blocks for interscalene for shoulder surgery, that is my target. Okay, so that is the interscalene brachial plexus. Okay, so we have seen the supraclavicular, we have seen the supraclavicular, we have seen the first rib. I go more medially, and there is a hyperechoic shadow. Anytime the hyperechoic shadow which is shimmering and moving, that is always the pleura. Right now what I'm seeing underneath the brachial plexus, underneath the subclavian artery, is the dome of the pleura. So we talk about getting the corner pocket, isn't it? So what is the corner pocket? That is the corner pocket. That is the inferior trunk. In this location, the way I'm holding the probe, if your needle came from there and you put it through thinking that you're going to get the corner pocket, and you go through the medial aspect of the first rib, and bing, you have a pneumothorax. So you can have a pneumothorax even with ultrasound if you did not identify the pleura ahead of time. So I always teach when I'm doing with my residents to angle the probe so that I can keep the first rib underneath the subclavian artery. Now, the hyperechoic shadow that you see there underneath the artery is that is the first rib, and that is the dome of the pleura. In this location, if I try to come under the artery, I'm safe because my first rib is going to protect me from entering the lung. So those are the few things about the supraclavicular block. Shall I go on to the infraclavicular? Okay, for the infraclavicular, for the interscalene, let me say one more thing. You can trace it coming from the midline. So at the level of the cricoid, when I put my probe, you see the trachea right in the middle. When I move my probe more laterally, you see the homogeneous ground glass-like appearance, which is the thyroid. I go more laterally, and I see the carotid artery, okay, and I go more laterally. I'm going to relax my probe, and you can see the jugular vein there. Okay, can you see the jugular vein there, where the arrow is pointing? So I'm going to go more laterally. You can take off the color Doppler. And the muscle that I'm going to see there will be the scalenus anticus, and where the white arrow is my brachial plexus. And I have identified the brachial plexus, and you could do the block at that level, which will be by and large C6. And you already see the C7 transverse process at the bottom of the screen. Okay, can you freeze it? Okay, okay. So I'm going to show you the C7 transverse process. Okay, that is the C7 transverse process, and the subclavian vertebral artery is in this location. That is the C6, C4, 5, and you can do the block coming from the lateral side, and that is the sternocleidomastoid. So we traced it from the medial side to the lateral side to get at the brachial plexus, or coming from the inferior supraclavicular towards the brachial plexus. Those are the two common ways I trace my brachial plexus. Why should I know from the midline to the lateral? Many times patients may have a fractured clavicle. Then I may not be able to get a good area where I can put my probe. So learn both the techniques when you are practicing. Let's go on to the infraclavicular brachial plexus. For this, I usually keep it at about 4 centimeter depth, because pectoralis major and minor muscles give you a certain amount of depth in that location. So I put my probe with the notch facing towards the head end, and I put it on top of the shoulder joint. So when I'm top of the shoulder joint, you can see the bicipital groove, and the bicep supraspinatus tendon. So can you? Okay. Okay, you can see the humerus. You can see the humerus, okay, and you can see the biceps tendon as a hyperechoic shadow in the bicipital groove. And I'm going to move the probe, maintaining the parasagittal orientation more medially. When I go more medially, I come across another mountain, which is the coracoid process. That is a coracoid process. I'm going to move my probe more medially and let my probe rest in the valley, I call it. And I come across a pulsation. There are two muscles covering the pulsation. The most superficial muscle is the, okay, so that's the infraclavicular first part of axillary artery and vein. Artery towards the head end of the patient, vein towards the foot end of the patient. And you can see the pectoralis major muscle covering, and underneath that is the pectoralis minor muscle. So when you watch around the artery, there are hyperechoic structures. There is one hyperechoic structure just to the 9 o'clock position of the artery. Okay. Oh, sorry. Okay, you can freeze it now. Okay. So I'm going to show you the structures. That was the axillary artery. That is the lateral cord. And this hyperechoic structure at 6 o'clock position is the posterior cord. I'm not seeing the medial cord in this location because, as I told you, they don't run parallel to each other. So I will have to rotate my probe to look at the medial cord a bit better. So I'm going to do that right now. So I get back the same location. So I'm going to rotate my probe ever so slightly. Now I can see the medial cord between the vein and the artery. Yeah, you can freeze it now. No, you have the, take the color Doppler out that degrades the image. No, sorry. In this patient, or in Paneerselvam, so you've got the lateral cord, okay. There is another little neural bunch that could be the musculocutaneous. The posterior cord has gotten mushy. In him, the medial cord is running between the artery and the vein. There is a stipple structure between the artery and the vein. That is his medial cord. So one of the things that they teach us to do is to look at this brachial plexus when you abduct the arm, okay? Watch it. All the nerves will group together and will ride lateral to the artery or superior to the artery. You can see the, can you freeze it for me? Okay, freeze it for me. Okay, in this location, because he abducted the arm, that is the artery, that's the vein area, all the neural structures are riding infralateral to the artery. So some people say, do the block with the patient in this position and put the needle somewhere here. You will get all the neural structures for the block. Okay. Yeah, I will. Yeah. So, okay. So now those are the brachial plexus and the artery, and I'm going to go more medially, and I'm going to angle my probe. And what do I see? I see the ribs and the pleura. Pleura is always shimmering. Okay, that is the rib. There is a shimmering pleura there. There is another shimmering pleura there. And when you calculate, okay, in that location, if you freeze it, I can calculate what is the depth of the pleura for me. I'll use my caliper, and that is my pleura. Okay, as the needle comes, my pleura is about 3.47 centimeters deep in him. He's nice and skinny. So don't use your 10 centimeter needle to do an infraclavicular block on him. Stick with 5 centimeters should be enough. And don't go beyond a certain depth because your pleura is still in your way. So these are the advantages of the ultrasound. Okay, shall we go on to the axillary? Okay. Okay. So with the axillary block again, I'm going to put the probe horizontally across. My paradigm is to have the notch facing laterally. Okay, so I'm going to put it right across the axillary crease. So what am I looking at? I'm looking at a pulsatile structure which is very small. That's because I'm looking at 4 centimeter depth. So I'm going to reduce the depth so that I can look at a big fat vessel. So that is the axillary artery. And when I relax the probe, and you can see the veins filling up on either side, okay? And you can see the hyperechoic shadow around the artery. And you also see the musculocutaneous nerve between the coracobrachialis and the biceps. That's your musculocutaneous nerve. And you see a hyperechoic white line, which is like an arc at the bottom. That is the conjoint tendon. Okay, this is a conjoint tendon. Okay, so usually the radial nerve runs right on top of the conjoint tendon, probably between 6 o'clock and 3 o'clock around the artery. So that could be the radial nerve. And you see a bunch of nerves there, which is the median nerve. Another bunch of nerves there. Sorry, this is sticky. That is the ulnar nerve. So when I relax, you can see it better. Okay. So my needle will come from the lateral side, and I will target this one first. When I stimulate the musculocutaneous, I get the biceps contraction. I'll come back out, flatten my needle, go towards that to get my median. I'll get the median twitch. I leave my nerve stimulator at 0.6 milliamp. Then I'll advance it further. I'll get the ulnar twitch. And once I get the ulnar twitch, I press the artery down, I go in this location, I see the radial nerve is somewhere there. Then you can trace all these nerves to their destination, okay? So that's the only way you can be absolutely sure that you are looking at those nerves. That I will show you during our individual scan sessions. And right now, does everybody see two arteries here? Let's put a color Doppler. As you come down, you will see the profunda brachii coming into view. So sometimes people mistake that for two axillary arteries. It is really not two axillary arteries. It's the profunda brachii, and I go up. See now, profunda has joined the main brachial artery, main axillary artery. Do you see what I'm seeing? Okay, so that is the brachial artery. Show the profunda. There we go. That's the. Okay, that's. Okay, you want. Okay, now you can see the profunda just underneath the main axillary artery. Okay, so that is as far as the axillary brachial plexus is concerned. So when I want to do the radial rescue at the elbow, I have a set pattern of imaging those nerves. Okay, so I put my probe horizontally across the lower 1/3 of the arm. So all I see is muscle, muscle, muscle. I'm going to increase the depth. I'm going to increase it further till I see what I call as the McDonald's sign. It looks like McDonald's sign, right? Sorry. So that is the anterior surface of the humerus. Okay, can you see the anterior surface of the humerus? So that is the anterior surface of the humerus. Okay, and I'm going to go more laterally. I'm moving my probe more laterally, and I can see a stipple structure just outside of the bone. So that hyperechoic shadow is one of the branches of the radial nerve. The other branch is in the lateral intermuscular septum. I'm going to move my probe towards the head end of the patient. Okay, so watch those two nerves. They will come together. They join together. Now they are going towards the humerus. Going. It's gone into the spiral groove. So that I know for certain is the radial nerve. So I'll come back out a little bit and have it in the intermuscular area. I'll go touch that nerve with my needle. When I stimulate, I get the extension twitches of the hand. I'll deliver about 5 or 10 cc's there. So that is the radial at the elbow. You may also do the radial just above the, just anterior to the, so that's the radial head, and you can see the radial nerve just superficial as a hyperechoic shadow. Does everybody see a pulsatile vessel along with that? So quite often when we do that block there, I can get some blood come in my aspirate, so you have to be very careful when you do the block in that location. Okay, that's another area where you can do the radial block. So what about the median at the elbow? We know median nerve is medial to the brachial artery. Okay, so this time, can you reduce the depth please? I've got the notch facing medially, okay? Just a little bit lower, okay. Now you can see you can reduce it further. Reduce it further. Make it as low, reduce it further. Some more. It can go up to 1.5, that's good, that's good. Okay, so now I'm going to look at the brachial artery. Okay, you can see the pulsatile brachial artery there, right in the middle of the screen. I'm not able to make a good contact with him because he's so skinny. No fat there for him, which is good. And you can see a stipple structure just medial to the artery, which is the median nerve. So you can come from the medial side, touch that median nerve, get the medial twitch, and inject in that intermuscular area. And you can follow that nerve. See, now it is diving down. Can you follow that for me? Okay, now it is diving down. Now you can see there. The white arrow is just next to the median nerve there. Okay, so you can trace it all the way down. You will have to increase the depth for me. Can you increase the depth for me? So I'm going to put my probe right across the mid forearm. In this location, I always say the median nerve looks like a jewel. No. Yeah, I got it. Okay. So now you can see the, can you point it to that one? Yeah. Dr. Marudachalam is pointing to the median nerve, so you have to press the arrow up there. Okay, so he's showing it with the pointer. That's the median nerve. Watch it as I come down in the forearm. So it becomes more and more superficial, more and more superficial. You could block it anywhere along its course, okay? So now I can, it's a very anisotropic, that means you have to angle the probe up or down to see the nerve a bit better. So as I come down closer to the wrist, I can almost not recognize it as a nerve because it looks like one of those tendons. But if you watch carefully, the stippling on the nerve looks a little bit different compared to the tendons. That is your median nerve. So you could block it only in that location to get a very distal, very short. So you can reduce the depth and then you will see it a little bit better. Okay, so that's the median nerve. Okay, let's go on to the ulnar nerve. For the ulnar nerve, I let the patient keep the elbow bent. I put my probe horizontally across the upper forearm. Okay, so what am I trying to look at? I'm trying to look at the flexor carpi ulnaris muscle, and that will be the boat-shaped muscle there. That's the flexor carpi ulnaris. Just underneath that is the ulnar nerve. So I'm going to reduce the depth a little bit. So I'm going to come down on the forearm. So in this location, the ulnar artery will come and join. So now you can see the ulnar artery lower down. So there is a vessel here. Watch this vessel. Okay, so as I come down, it's coming to join the ulnar nerve. Can you see the ulnar artery and the nerve together? Let us put a color Doppler to show the artery. Okay, that's the ulnar artery, and next to that is the ulnar nerve. So I don't block it when it is so close to the artery because I don't want to ding the artery and get a hematoma. Take out the color Doppler, please. So I will come back up in the upper forearm till the ulnar artery is away from my nerve, and I can do an in-plane or off-plane access to that nerve and get an ulnar twitch and deliver the drug there. So that is the ulnar in the forearm. Those are the common blocks that I do with the brachial plexus. With these blocks that I have shown, you can pretty much do any surgery that you want to do with the hand and the shoulder. Thank you. Thank you very much. Oh, this is not the word. Thank you.
Thank you very much, madam. That was excellent exposition, and it was so nice to scan, and this forms a real good base to take off. And from now on,